Thank you, ladies and gentlemen. Thank you for this kind invitation. So the next 20 minutes or so, we're going to look at some of the respiratory issues that's faced by children who have tracheoesophageal fistula. I would like to start with some acknowledgements. I'm very privileged and thankful to the families and children that we look after. I'm the face of the respiratory department. There is quite a lot of work that is done at respiratory department, so my sincere thanks to that, and also the TOFs. I don't have any conflict of interest relevant to this talk. So in terms of respiratory complications or respiratory issues, the first problem is floppy windpipe or tracheomalacia. As Mr. Lander referred to and explained, that majority of the children, about 3/4 of children with tracheoesophageal fistula will have an element of floppy trachea. So the floppy trachea in itself, as with many of the other difficulties these children have, they learn to live with it. They can manage. It tends to cause them some respiratory symptoms, but majority of them learn to cope with this. But in some children, especially in infants, it can cause severe breathing difficulties. So the cyanotic spells or breath holding spells that we refer to, I'll come to that in my next slide. And in older children and adults, it can make them susceptible to chest infections. So we will touch on that a little bit more in the next couple of slides. One of the severe symptoms of this floppy windpipe or tracheomalacia is the cyanotic spells. So this is where the baby starts crying. It's usually seen in infants. There is very severe floppiness, and the baby starts crying. And that crying essentially means a gust of air actually is expelled from lungs out. And that, as the trachea is floppy, as the air gushes out, it can cause a negative pressure and suck or make the trachea collapse completely. Now, the way the lungs are designed is that a small amount of residual air is within the lungs. So if you imagine a balloon, the hardest part of inflating the balloon is the first part, when you have to actually inflate it. And then after the balloon is inflated a bit, inflating it further is not an issue. So the body is designed that always there is some residual air in your lungs. So lungs do not completely collapse. But in tracheomalacia, sometimes because of the severe floppiness of that airway, the trachea just closes off, and then the children can stop breathing. It's quite a fairly serious condition. Now, this is more commonly seen in children who have had other difficulties with either their swallowing, or they often have problems with esophageal strictures and so on and so forth. Now, in these children, we may have to consider iotopexy, as Mr. Landers referred to this operation earlier in his talk. So the iotopexy seems to actually help these children. So the tracheomalacia, the floppiness doesn't go away completely, but then you have opened up the windpipe sufficiently enough that sort of a breath holding spell doesn't happen. Very rarely, these children may need a tracheostomy. So because the trachea is just collapsing, very rarely in our service in the last 12 years I've been at Children's Hospital, we've probably had 2 children where we have had to make a hole in the neck and put a tube that either holds the trachea out through a tracheostomy. And we have had one child where not only have we had to put the tracheostomy tube, but that wasn't in itself sufficient. We had to connect onto a breathing machine which would blow continuously some air to splint the trachea. But that's fortunately, these sort of severe spells are very rare. And when they happen, we can usually address them with iotopexy. The other problem, fortunately with the tracheomalacia, various studies have shown that it gets better with time. So it's more common in infants, and as they get older, so if you look at the proportion of children who still have floppiness, it drops from about 29%, as in almost 1 in 3 children having this problem, to 10%, 1 in 10 adults having this problem. But as this tends to improve, what basically it results in is ineffective clearing of mucus from lungs. So the lungs, the way the lungs are designed, they produce a lot of phlegm or mucus. And the reasons the lungs produce this mucus is that is its way of protecting itself from all sorts of horrible things that we inhale with every breath. So these pollutants or bacteria, they're trapped in this mucus, and then there are little tiny finger-like structures on the lining of the lungs called cilia, which you can only see under the microscope. They beat in a coordinated fashion, and they move along these secretions. The secretions get cleared off. But when you have a floppiness of the airway, so the part of the lung that is distal or that is beyond that airway, the secretion doesn't move. So that results in a bit of pooling of secretions in your lung, and that can predispose to infections. Now, we produce more phlegm with any viral infections, and it is natural for babies to have, as they grow, have infections. Having viral infections is part of your growth. Now, the excessive production of this mucus then predisposes to these chest infections. So that tends to be more what we tend to see in our clinical practice is this recurrent chest infections. We know that children, if you did a survey of these children with Tracheo-Oesophageal Fistula, more than 80% of these children have had a significant chest infection at least once in their childhood. So this is significant enough for them to have gone to the general practitioner or gone to the A&E, have had some antibiotics. So these are not the little bit of cold or bit of cough and it's gone away. So it is quite a significant morbidity. And this starts with a viral cold. So the dry TOF cough then turns wet. Now this is where a number of health professionals do not recognize this. So parents are very clear that this is a different cough. Whereas the health professionals cannot sort of recognize a significant cough. That is one of the issues that we find mostly, I mean, not only in primary healthcare, but also in if they did come to A&E. So spotting what's a significant cough in these children is very difficult. So they get sort of dismissed as something insignificant, sent away, and things like that. Majority of the time, these children are not unwell. So yes, there is a proportion of children who will develop huge fevers and they are very unwell, but majority of them are still running around in the clinic perhaps, but it is causing them cough significantly to the extent that the oral intake has reduced, they're not sleeping well at night and so on. So it is a major problem for this child and family. The other problem is when we listen to the chest with a stethoscope, the chest often sounds clear. And therefore, when these kids have been seen by A&E doctors or in general practice, they have been just falsely reassured. So the chest sounds clear. As a result of this, the chest infections are not spotted early enough, and they are not treated early enough. So this can result in quite a bit of trouble for these children. There are 3 patterns of chest infection. And the first pattern is probably more typical. Now, any child from this time of the year until next March has a bit of a runny nose. That's normal. And having at least another 3 or 4 sort of viral infections during the course, at least in the first year of life, is common too. And one infection almost goes from, well, the infections go from one infection to another without any break at all. Now, this pattern is not usually recognized. Now, the lack of continuity in care in general practice or in A&E means that that connection isn't made, that this child was with us just 3 weeks back with a bit of cough. They are there with another new cough now, etc. So, because they are so well looking, it is often under-recognized. The other pattern of chest infections is severe chest infections. We do occasionally see children where they develop a pneumonia. So the pneumonia is a severe bacterial infection in a part of your lung, to the extent that they may run into so much of breathing difficulty that they can end up on intensive care unit. Now, that presentation, fortunately, is very rare. But the third part is, okay, they may not get severely ill to the extent that they need intensive care, but they still have, they have to be in the hospital and they may require intravenous antibiotics. Now, because they are within the hospital, probably somebody will think about tracheoesophageal fistula and the connection with tracheomalacia and the chest infections and start some preventative treatment, perhaps. But, even in our institutions, even in our organization, we are not very good at that. We're getting better, but definitely we are not there yet. So recognition is a major problem, and it is not unusual for us. Many years back, when these children would come through GP, the parents would have a sigh of relief. At last, there is somebody who actually understands our problems, So we are sitting there in the consultation and saying, yes, your child has a significant chest problem. Now, this is a chest X-ray, and again, this doesn't show a lot of changes. Now, the point I'm trying to emphasize is, unless we look for this problem specifically, ask leading questions, we are not going to find it. So this is the heart, that's the stomach, it's a rib cage, and there is a little bit of changes on the right side and as well as on the left side. Some children have lots of chest infections even when they have had the right treatment. They have had the antibiotics, they have had the physiotherapy and so on, which I'll come to in a bit. And in those children who tend to have lots of chest infections, we go through a list of other reasons why this might be happening. As we've heard, abnormal swallow, and therefore the food or the milk going down the wrong way into the lungs. We have to consider that. We know these children have esophageal motility problems, so therefore the food from the food pipe can then spill over into the lungs. Reflux, the same thing can happen, very rarely recurrent fistula. If there is a stricture, I have a number of children who, as they are due for another stretch, a week or 10 days before, they start being chesty, so there is a little bit of spillover into the lungs. And they can have some abnormalities in the way the voice box has been put together, larynx has been put together, so that can happen too. So in small group of children where we are having difficulty with sorting their chest out, these are the range of things that we consider and sort of investigate a bit more. So what can we do about these chest infections? First is prevention. So as far as possible, we would think about preventative strategies. Childhood immunizations, now the immunizations covers at least the vaccines covers two major bacteria that cause chest infections in the normal childhood immunizations, the Hib as well as the Prevenar, that's a pneumococcal vaccine. We would actively advise the flu vaccine, which is now available. It should be available at your GP surgery now. And the thing with flu vaccine now is that there is a nasal spray for children. So nasal spray is an option too if they don't like injections. Early recognition is very important. Now, if we are able to pick up these infections just as they have started, then controlling them or treating them is easier. So as soon as the nature of the cough changes and children and parents can recognize this, what our strategy has been actually, they either get in touch with us through our specialist nurses. So we take a bit of a history. They may not necessarily need to come and see us. So if there is a wet cough now, we would tend to treat them early with antibiotics. Now, we have extrapolated this experience from other conditions where we get recurrent chest infection. So there isn't a particular research specific to this, to tracheoesophageal fistula, but when we extrapolate our experience from other conditions like the cystic fibrosis, the ciliary dyskinesis, and so on and so forth, we know that early antibiotics will result in decreased severity as well as decreased duration. We also know that the antibiotics may need to be higher doses and for longer duration. When you have a good going pneumonia, so that is where a child is flushed, a fever, they are panting away, and they have a patch of infection in the lung, the body increases the blood supply to that part of the lung. So you could use standard doses of antibiotics. Antibiotics is preferentially taken into that bit of the lung. Whereas in these children, it is a more what we would call as a subacute infection. So the infection is not raging, but it is still there. And there may not be preferentially increased blood supply to the lungs in these children. So therefore, in order to get more antibiotics into their lung, we may need to use higher doses. Now, we would not go straight away to the higher doses, but then that is dependent on each individual child. If we could settle it down with standard doses, then we would. Similarly, we may need to use it for longer duration as well. So a course for 5 days may not be enough. So sometimes a course for 10 days or even 2 weeks might be necessary to completely eradicate the infection. We think about preventative antibiotics. Again, this is something we've learned from other similar conditions. Now, occasionally in our children's hospital, Birmingham, we tend to use a medicine called Ceftriaxone or cotrimoxazole, but it could be any preventative antibiotics. Now, if the child has a history, especially during the winters when one virus after another, they have constant chest infections, and maintaining them on a small dose of antibiotics could be helpful through the winter. Parents are naturally worried about one of the questions I got asked is being on long-term antibiotics, does it affect your immune system? It doesn't affect the immunity or immune development of the child, but what we would be worried is having a child on long-term antibiotics is the antibiotic resistance. The bugs could get clever and they could develop resistance to the antibiotics. In small group of children, we feel chest physiotherapy is helpful. So I will spend a couple of minutes on that. But before that, we would use common antibiotics. Now the bugs that cause infections in the lung are similar to the sort of bugs that would cause infections in any other child. So we don't need to use any special antibiotics for these children. So the antibiotics that we would think about are co-amoxiclav, so that's augmentin. GPs generally prefer amoxicillin. Amoxicillin may not give such a good cover against certain antibiotics, so sometimes what we have advised our families is if they have trouble, then they contact us, and we do a fax across to the GPs to request them to give a specific antibiotic. Sometimes we think about azithromycin, and as a set course of about 10 or 14 days. We've increasingly started to use chest physiotherapy. So again, this is extrapolating our experience from other conditions. In little children, toddlers, it may just be percussion, that's patting on the chest. Some families do it through the winter just to keep the lungs healthy, just keeps the phlegm cleared in the lung, so that if they were to contract any infections, then at least their lungs is in a good state and it can deal with these infections better. In older children, there are other devices called acapella. The other thing we've started to use more and more is nebulizers. So nebulizer is a solution that's actually aerosolized, so it basically comes up as a mist. And the medicine that we've started to use more is a saline solution. It is a very strong saline solution. It's all, being on a beach. Quite often respiratory patients come back and say, well, we were on the beach, it helped our breathing. That's because the saline solution actually hydrates, or it makes your mucus thinner and the mucus can clear. So we've started to use more of hypertonic saline than we probably used to use before. So percussion is essentially patting of the chest with cupped hands, so it is done in different positions. And because of the reflux, we wouldn't think about having head down at all. Previous many years, 10, 15 years back in cystic fibrosis, we would have children hanging upside down to aid secretion clearance, but that wasn't very good for the reflux. In fact, the chest got worse. So we have stopped doing that. And it becomes less effective with age. At about 10, 12 months, they are mobile. You can't pin the babies down, so they start running around, it becomes less effective. But for older children, there are more interactive devices. So this gives a little bit of positive pressure. So as the child is breathing out, it applies a bit of positive pressure, keeps the lungs open a bit, so that they can bring up the secretions. And with something like this oscillatory pressure, as the child is breathing out, it opens the lungs, but also it vibrates the secretion. So it basically, it shakes up the secretions inside the lung, and it can be, children will clear it, but they are not going to spit it out. But as long as it clears from the lungs, then it's done its job. Exercise is fantastic. So exercise is a form of chest physiotherapy. So a lot of exercise is encouraged. And in older children, we would just introduce this concept of huff. So as the children have done an exercise, they do that sort of a huff, which clears the phlegm from the chest. And of course, there are other benefits of exercise too. So the last bit I wanted to touch is on wheeze. Now, wheeze means different things to parents and different professionals. So wheeze to us is a whistling noise. That sort of a whistling noise as the child is breathing out. With a floppy windpipe, it can cause wheezing. So the floppy windpipe, especially when the child is active and running around, that in itself can cause wheezing. But sometimes wheezing gets worse with secretions as well. When there is an infection, then the wheezing can get worse. 1 in 11 children in UK have asthma, so these children can have asthma too. But one thing we exercise caution in treating of this wheeze is use of the blue inhaler. Now, if the windpipe is floppy, there is a theoretical risk that the muscles that are keeping the windpipe open, if we relax those muscles by giving them the blue inhaler, then it may make the floppiness worse. So blue inhaler, we wouldn't say is an absolute no-no, but we would certainly advise use with caution. And certainly in our A&E, when a child presents with wheeze, if they don't respond to one set of blue inhaler or a salbutamol nebulizer, then the temptation is to give more. So, sometimes just bearing in mind that by giving more of the salbutamol, we may actually make these children worse is important to be kept in mind as well. So if we were going to use the blue inhaler, we would use it initially under medical supervision, and then if it doesn't make the child's symptoms worse, then we would advise it to use accordingly. So this was just a quick tour around the respiratory issues. But I think the thing for us is the respiratory difficulties are so non-specific, the symptoms are non-specific, that unless questions are directed and the information is teased out, these difficulties may be under-recognized and therefore under-treated. Thank you.
Satish, thank you for a very interesting discussion on respiratory problems. Let's take questions.
Hi there. I have a nearly 5-year-old, and what you describe is our winter, really. My question is, when you had your slide about them being well and they're still running around, but the coughs move from dry to wet, would you expect them to have a temperature?
No.
Right, because I don't tend to respond until she's had a temperature, and I can categorically say, fact-based, she's had a temperature for 48 hours, so am I leaving it a bit late, perhaps?
These children, they may not develop a temperature at all. Now, initially, what we would say is that if the cough turns wet, it is reasonable to wait for 24, 48 hours. There is no hard and fast rule on how long you would leave it. But certainly after 2 or 3 days, if the cough shows no signs of settling down, then certainly antibiotics would be advised. The only reason why we want to intervene now is 2 reasons. One is we know these chest problems get better as they grow up. And in the meantime, we are just stopping them from developing any long-term scarring in their lungs. So.
Thank you.
Satish, can I just ask you a quick question whilst we find the next question, which is about antibiotic resistance, because what you're advocating is liberal use of antibiotics in children with esophageal atresia. But what about the long-term consequences of that?
Okay. I mean, the liberal, in terms of, again, there isn't evidence specifically for tracheoesophageal fistula. But if we extrapolate our experience from cystic fibrosis is a different condition. We'll leave cystic fibrosis aside. But if we look at children with similar difficulties who do not have cystic fibrosis, number one, we know that early aggressive treatment in the young age essentially means it resolves in a few years. In some children, it is few years. In very small proportion, maybe much longer. During that process, there is a risk of antibiotic resistance, but I think the benefit of having them on longer treatment or prophylaxis outweighs that risk. Now, in our experience in other children, one bug that we see some resistance with is the Haemophilus. Haemophilus develops resistance much more easily than others, and azithromycin is the antibiotic that it develops resistance towards. So we tend to avoid that. Yes, we need to use antibiotics cautiously, but in this particular children, I think it is justified.
Thank you. Mr. Lander can have one quick
Satish,
question.
I think this respiratory thing's really, really important, because I certainly know that I've had children who are now adults that gone through university, got jobs, whose chests aren't as good as perhaps they should have been. And they've had bronchiectasis and stuff, and I think we probably undermanaged their chests when they were little. Now, you've explained very nicely that, one, you don't always have to have a temperature, that you can go from one minor chest infection, which are common in children, to another minor one almost straight away, to another minor one, and that the medical professionals will just treat or pick up the current episode and think that's no different from everybody else I've seen with this. Now, and we've got the worry about inappropriately treating with antibiotics, is there a role for the expert parent to have antibiotics that they can give when they know and have been appropriately guided, I am now going to start antibiotics? Or is that wrong?
No, that certainly there is a role. With these little ones, the way we've managed, you may know, is as part of a treatment plan. And it is not unusual for some of our families to have antibiotics to start. That's certainly a strategy that we have followed in children who tended to get very unwell very quickly. I think the difficulty is otherwise. My anxiety is these symptoms are not picked up elsewhere. So, I think they have, for us in our service, the parents and families have access to us 24/7. So through our specialist nurses Monday to Friday, and there is always a medical doctor on call. So they would actually contact us if there was a problem. But also each child will have an individualized plan. I think there is definitely a role, Tony, in short. Yeah.
Okay, we've got a question from the gentleman over there.
Okay, so my son was obviously diagnosed, treated for the TOF and everything like that. And when we took him home with ranitidine on a small dose, which he would take twice a day. He then went in for his dilatation, and after the dilatation, he was then prescribed with erythromycin, also on a low dosage, but that wasn't used as an antibiotic.
It was reflux, yeah.
Yeah, it was used as a reflux. Now, the erythromycin was used for the reflux, as well as the ranitidine. Would they not have kind of battled each other?
No, the ranitidine and erythromycin in that context has been used more for reflux, isn't it? That's basically, erythromycin has been used as to increase the gastric mobility.
Yeah, but would that not have sped up the resistance that you were talking about?
The erythromycin at that dose, generally resistance is not a problem.
Okay,
Yeah. No, sorry.
Any other questions?
has the Tracheo-Oesophageal Fistula Support and he's had an issue with vomiting, and he had a pH test and the results came back not really severe reflux, sort of moderate reflux, and he had the fundoplication, and then he's had a reoccurrence of symptoms and with the vomiting, and he seems to have a lot of mucus, always in the morning, lots of mucus, and that seems to, it coughs a lot, the mucus, and then he brings up his milk. And so when I've been researching, one of the things that I sort of came across is this bronchiectasis.
Bronchiectasis, yeah.
Yeah, I was wondering if you thought that had any, it's difficult to say for an individual child, but he's not developing chest infections, but whether you think that could have any bearing on the vomiting.
Okay. Bronchiectasis is a term that's given to a long-term scarring in the lungs. Now, usually bronchiectasis develops over a number of years of having recurrent chest infections or constant chest infections. So it doesn't sound like, from what you have said, that your little one has bronchiectasis. I think it is a reflux we know causes a lot of secretions in the oropharynx. But if your child doesn't have a constant cough, a constant wet cough, then it's probably not bronchiectasis.
Hi, my son's 24. Obviously, every time he goes to see a doctor, it's a different doctor. You bring up the subject of TOFs, they don't know what it is. He gets sent away, chest infection gets worse, he's got to have time off work. What would the best way for him to explain? Is there a leaflet or something that he can carry for every doctor that he sees?
I don't know is the answer to your question. I guess.
You get 10 minutes to...
Correct. Yeah. Now, in terms of the children that we look after, we have an acute plan that is shared with the general practitioners. So we have a plan that is, for that particular child, which the general practitioner has it on their system. And the families have a copy of that letter. So when they do go to the general practitioner or to the A&E, then they have a piece of paper that says, well, this is what needs to happen with their child. So it may be something, now again, are they under a respiratory physician? Is that an option to have an individualized plan for them? It's something to think about. Yeah. Okay.
Okay, we've got a question in the back. Yep.
Hi, I am a TOF as well, so I just want to ask a question. In chest infections, how is it? How can you how does the amount of food or what food you eat it just affect like your chest infections?
Okay. So the food per se and causing a chest infection is not common. What food you eat will not cause a chest infection, but if that is the sort of foods that doesn't flow down your food pipe easily, then there is always a chance that can spill into your lungs. So some parents and some children feel, well, if I had ice cream or a cold drink, I will develop chest infection, I'll develop wheeziness, but it's usually not the case. It is related to whether that food can flow down your food pipe easily or not.
Okay, thanks.
Okay, lady in the front over here, and then the lady over there.
Yes, thank you. I was wondering about the preventative antibiotics you were talking about, because my daughter, what happens is just, as you said it, she starts with a runny nose, and her respiratory doctor said, kick into the azithromycin. Thank you very much. And that will prevent it, knock it on the head, because obviously it got very worse at the beginning, and then we figured out this is the plan for her. But the winter's coming in, and she's a 2-year-old, so the preventative antibiotics, which ones would you recommend? Because the other antibiotic is, I understand, very high up, and there's not a lot of places to go after that antibiotic if it doesn't work.
So again, preventative antibiotics we use in a small group of children. We don't use it for everyone. Just because there is always a risk of using a medicine. Now, the preventative antibiotic we've tended to use is something called Septrin. The actual name is cotrimoxazole. So it is one of those antibiotics that has been there for decades. And the reason we use that particular one are for two reasons. One is it's been around for a long time. And the second reason is the antibiotic resistance. The bugs developing antibiotics resistance to that is very, very small. There is a third reason. The third reason is then you have the azithromycin or the augmentin in your pocket to use it when there is an infection. So Septrin is the trade name. Cotrimoxazole is the... So there are two risks with that, apart from long-term use of antibiotic risk, which is always there. One is allergy. It can cause an allergic reaction, and in some individuals it can be quite a severe allergic reaction. So it's difficult to predict whether somebody is allergic or not. And the other side effect which we keep an eye on is it can affect some of the cell counts in your body. Now again, in our experience, we have not found that as a problem. We use it quite safely in our practice, but that's another thing which we need to keep an eye on.
So you would probably recommend for parents to do it on a case-by-case
basis. Case-by-case.
And don't go
so preventative,
long-term.
Absolutely. Preventative antibiotics, every child doesn't need it. It's a very small proportion. And I'm talking about children who have had, rough summers. They have been more or less, chesty, and they have had lots of antibiotic courses. It is that group of children. It's not required in every single child.
And the amycin, cyprin, I was told by my GP that's way up the Richter scale. He didn't want to give it to her, but the respiratory consultant said, yes, actually,
correct.
That's the one.
Azithromycin is again a class of your commoner antibiotics, but azithromycin, the risk of the bugs becoming resistant is a bit higher with azithromycin. And normally azithromycin is used as a course for 3 days. That is what it is usually used for. And the other things that GPs will sometimes question us is, well, actually we are using it for a week sometimes, or 10 days.
Is there any other one you'd recommend?
Coamoxiclav is another antibiotic. So these are very common antibiotics. So these are sort of antibiotics which are not what we call as broad spectrum antibiotics. So these are simpler antibiotics.
My son's nearly 3. He's got Tracheomalacia and also subglottic stenosis. He's been really lucky so far that he's not had any significant chest infections, but this year he's eligible for the nasal flu vaccine. Is it something that I'm okay to give him, or in your opinion, should I be pushing for him to have the jab?
When the nasal flu vaccine came a few years back, we were a bit worried because it's a live vaccine, live but inactive vaccine. In children with chest difficulties, will it cause a problem? But there is now plenty of research to say that it is safe. So we use it in children with cystic fibrosis and so on, where they have much more scarring in the lungs, and it hasn't seemed to cause any problems.